Okay, good morning, everyone. My name is Quentin Eichbaum. I'm the co-chair of the AFREhealth-CUGH working group, together with Dr. Abigail Kazembe, who's the incoming current president of AFREhealth. And we will be opening the session today. Welcome, everybody. We realize it's early for many people and late afternoon for others, but we're very thrilled that you're all on the call today. We have a very packed agenda, and I'm going to take you through that all. And then I'll say a little bit about CUGH, and Dr. Kazembe will introduce you to AFREhealth, and then Dr. Kigula Malwadi will give you a little bit of the history of CUGH, but I will give you the program in a little bit. So let me just upload my presentation here. Why is this uploading correctly? Dr. Mazzola, I think you need to stop sharing. Your slides are still up. Dr. Mazzola, I think your slides are still up. So.
Okay. Quentin said we were seeing your screen.
Huh?
It says we're viewing Quentin.
Yeah, but that's the wrong talk. I don't know. What are you seeing? Collaborative course of online teaching? Okay, there we go. All right, here we go. Sorry about that. So just a few logistical issues today. All attendees are muted. Your video can be switched on. We just clarified that. So you can have your video on or you can have it off. Very briefly, we have two buttons at the bottom. There's a Q&A button, which is strictly for questions. The chat box is only for comments, not questions. So if you have questions, put them in the Q&A box, not in the chat box, because we will not be monitoring the chat box for questions. When is the Q&A session? That will be probably after Dr. Nkengasong's talk and at various other points in the course of the presentation.
No, I'm halfway down the stairs. Where should
Hello?
I go?
Could we mute everyone, please? Could we mute other speakers? This is the program we have today. Myself, logistics and backstories, and Dr. Kazembe will be speaking. Then we'll have Dr. Kigula Malwadi, the keynote speaker. We'll have a short talk on capacity building platform. Then each of the three subcommittees will be presenting some feedback and forward feed for about 8 minutes, strictly, no longer than that. Here are the co-chairs of those committees. And then we will break out into 3 separate breakout rooms that will be research, students, and education. And you'll see the names for those. So look out for those at that time, 9:25. And that's a 50-minute session. Some of those sessions will have short presentations by speakers, mostly in the education session. So decide where you want to go. The groups will then end and we will reconvene and get report backs from each group. And then we'll wrap up. Dr. Kigula Malwadi and I will wrap up the session with questions and summaries. So just a few slides about CUGH for those of you who don't know about it. It was founded in 2008 with seed funding from the Gates Foundation and the Rockefeller Foundation. It was amalgamated into a group called GHEC in the 1990s to form CUGH. The Secretariat was established in Washington in 2012. Currently, it's the largest academic global health organization in the world with over 200 academic institutions, and we have other associations and NGOs and a network of 30,000. The mission is to support academics, institutions, partners to improve health of people and the planet across research, education, and service and advocacy. So that is about CUGH. There are several major committees. The ones in red here pertain mostly to the AFREhealth-CUGH working group, the education committee, that is a big committee with 8 subcommittees, and the research committee, and then several others. The Education Committee has lots of subcommittees. I used to chair that, currently chaired by Dr. Rabin and Hudspeth. There are several working groups and task forces. It's a big operation and a very, very active group. Something about the ACWG, the AFREhealth-CUGH working group, was actually founded in 2017 after the meeting in Accra, Ghana. I remember very clearly myself and Dr. Mariki de Villiers, the former president of AFREhealth, talking informally about it, and during the year, and Elsie Kagula Malwadi discussing how to set this up. At 2018, we had established 3 subcommittees, and at the subsequent meetings, we were having separate sessions already and discussions. 2020 was a gap year. We then laid out possible areas of interest, was all mapped out like this. You can see them laid out here into professional learning, leadership, student exchanges, education, research, and we struggled to know where we should focus. And we even mapped these against the committees at CUGH and with the former technical working groups of the former MEPI, and AFREhealth grew out of MEPI, let's recall that. And we were trying to see how we could match up what was available at CUGH with what had been available in the former MEPI. But eventually, and this is my last slide, we decided to start off with the 3 working groups we currently have: research, education, and student exchanges. So that is where we are today. And this is just a photo of Elsie Kagula Mawadi, Dr. Mariki de Villiers, and myself, who formed this working group that has remained active since then. And here we are today in the middle of a pandemic, still having these rigorous discussions. And I think the group has gone from strength to strength. So thank you very much. I will now hand over to the AFREhealth president, Dr. Abigail Kazembe, to give you an introduction to AFREhealth and from their perspective. Abigail, are you ready?
Yes, thank you so much, Quentin, and welcome to you all to this session. Clara, can I have the slides up? I think Quentin has already talked about some of the issues that I'll talk about, so I'll really go fast. Our association is called AFREhealth, and it is basically an interdisciplinary health professional grouping which works with ministries of health, training institutions, and other stakeholders to improve the quality of healthcare in Africa through research, education, and capacity building. It is a conglomerate of individuals, institutions, associations, and networks across the geographic and linguistic regions of Africa. You know, Africa has so many languages, and membership is open to all within and outside Africa, as long as you are committed to an Africa with a strong improvement towards quality, and especially in our health systems. Next slide. How did AFREhealth come into being? As indicated by Quentin, it was established in August 2016, but registered in Ghana in November 2017. It is based at the Kwame Nkrumah University of Science and Technology, Kumasi in Ghana. It is an independent body that emerged from the Medical Education Partnership Initiative and Nursing Education Partnership Initiative, MEPI and NEPI. This was a grant that was funded by PEPFAR, the NIH, which ran from 2010 to 2015. Next slide. So basically, this just shows you the locations of the MEPI. The NEPI program was based in 6 countries: DRC, Ethiopia, Lesotho, Malawi, Zambia, and South Africa, while MEPI was based in 12 countries: Ghana, Nigeria, Kenya, Uganda, Tanzania, Botswana, Zimbabwe, Ethiopia, Mozambique, Malawi, South Africa, and Zambia. And after the MEPI grant expired, there was a there were so many gains which we felt could not be wasted. So the idea was to set up and institutionalize and sustain those gains in terms of some were knowledge related skills, and also there were initiatives that were developed during that time. And also we also had networks which we felt that would support the idea. So the main issue was the sustainability. And following that, there was a meeting that was held in Addis Ababa, Ethiopia, whereby the NEPI PIs met some of the implementers for the NEPI programs. Unlike NEPI had one PI, but was working in 6 countries with 22 schools of nursing. And that's how we started. Thereafter, there was a task force that was developed. And then finally, we launched the association. We are in so many countries right now, in so many training institutions, and we have a number of partners. These are just a few of them, which you can see on the screen, but the list can go on and on, because we have developed as we call ourselves a network of networks. Next one. And in terms of governance, it is governed by council members from different health professions across Africa, led by a president. I'm the current president for AFREhealth, and I'm from University of Malawi, and Vice President Elsie Kiguli Marwade from ACHEST, and also membership is open to all individuals as well as institutions. And you can download a membership form at that address. Next. Okay. Our vision statement is to be a responsive health workforce for building relevant, high quality, evidence-based healthcare in Africa. And our mission is to provide African leadership for responsive health professions, education, training, research, and service in order to contribute addressing key health priorities, including HIV and AIDS, TB, HIV, malaria, maternal and child health, NCDs, and other emerging diseases such as COVID-19, and also repeat epidemics and pandemics. Regarding the committees and other structures, we kind of mimic our big brother, CUGH. So this is just a brief overview of AFREhealth, what we do and where we are. Thank you.
Right, thank you, Dr. Kazembe. I think we're ready now to hear talk by Dr. Kiguli Marwade on the genesis and vision for the AFREhealth-CUGH working group. Elsie, are you ready? Do you have any slides to show?
Yes.
Go ahead.
I'm ready. Just give me a minute. Okay, thank you, Quentin, and thank you, Abigail. It's an honor to be at this virtual meeting, and thank you all for joining us. Just briefly, I'm going to go through the background for the AFREhealth and CUGH group that we formed. So what is the progress? Some of this Quentin has already did too. So we started 2017. We had a conference workshop at the AFREhealth Symposium in Accra, Ghana. And at that time, as partners, we got together and talked about our interests, trying to find out what we could do together. We continued working and talking together between 2017 and 2018. And then we met again at a satellite meeting at the CUGH conference in New York in March 2018. And still we explored possible areas of collaboration. And as Quentin showed, we distilled those areas of collaboration because there were many. So we met again in 2018 in August in Durban, South Africa, reviewed those areas that we had distilled and narrowed down to 3 working groups. And then we formed these 3 volunteer jumpstart groups that started working. And we had another chance to meet face-to-face at a workshop at the AFREhealth Symposium that we had in Lagos, Nigeria in August 2019. We reviewed the work that had been done and then continued with plans, and we made plans for 2019-2020. Unfortunately, as these work plans were being implemented, COVID-19, this caused a bit of delay in the work that we're doing because of the many reasons that all of you know. So in between, we've been meeting online, but not much work has been done. So we decided to come together again at this virtual conference and review our work and meet and see what we can continue to do. So our activities are mainly conference workshops that we've said. We also have small group discussions. Sometimes they are face-to-face. Before COVID, some of them would be face-to-face, but most of them are mainly virtual. That is one small group that must have been in Durban, one of the small groups that discussions we had there. Then we have virtual meetings like this one, and we have discussions with the AFREhealth Executive Committee to brief them about what we are doing, and also to get to compare notes and see how to move forward. We've made several presentations to the AFREhealth Governing Council, and as I said earlier, we have online discussions to be able to continue with our work. So these are some of the ideas and possible areas of collaboration that we started with. You can very many, and them actually put them out, people discuss them, and eventually we distilled them as Quentin told you. So we first of all came up with 6 groups, but we still thought these were too many, and some of them actually were quite similar. Interprofessional learning, there was education for health system strengthening, health professions, education capacity development. So you can see that some of them were actually interlinked. So we decided to distill them further and remained with 3 working groups. That's the research and leadership, and then interprofessional health professions education and student exchange. So the last time we met face-to-face, we asked each of this group to register their members, have a listserv, come up with the terms of reference and tentative work plans, and also plan to hold meetings and see how they could work together. And this, as I said earlier, was ongoing, but then COVID-19 came and disrupted some of the work, but some continue to work. This is an African proverb that is quite popular in AFREhealth. It says, if you want to go fast, go alone. If you want to go far, go together. And so as AFREhealth and CUGH, we want to go fast, so we are going together. And we would like to thank members of CUGH. They've really supported AFREhealth, because AFREhealth began far much later after CUGH had been in existence. So they've given us a lot of support, and we are really grateful. And our past president, Mariki de Villiers, actually added that leaving no one behind. So as we go far, we want to all go together, and we don't want to leave anyone behind. And that is our vision that has already been highlighted by Abigail, our president. We want to have a responsive health workforce, providing relevant, high-quality, evidence-based healthcare in Africa. And we believe in AFREhealth that this is possible. And we are beginning small, but we know that we'll go far if we work together. And we have partners, and one of our strongest partners is CUGH. So I think that's all I have to say about our progress, and I'm sure there will be more to come during our discussions. Thank you very much. Over to you, Quentin.
Thank you, Elsie. That was a very nice presentation on the history of how we've come to be where we are. We're moving straight ahead. We're sort of still on time. I'm going to ask Dr. Peter Kilmarks, who's the Deputy Director of Fogarty International, that has been a major supportive partner of AFREhealth, to introduce our keynote speaker, whom I hope is available, Dr. Nkengasong, the Director of Africa CDC. Peter, are you available?
Yes, thank you, Quentin. And I see Dr. Nkengasong is here, so it's my pleasure to introduce our keynote speaker. Dr. John Nkengasong has served since 2016 as the first director of the Africa Centers for Disease Control and Prevention, the Africa CDC. Prior to this, he worked in a number of leadership positions with the US CDC, including Associate Director of Laboratory Science and Chief of the International Branch in the Division of Global HIV/AIDS and TB. Dr. Nkengasong is from Cameroon. He earned his undergraduate degree at the University of Yaoundé, a master's degree at the Institute of Tropical Medicine in Antwerp, and a doctorate from the University of Brussels. He's also trained at the University of California, Berkeley, with support from the Fogarty International Center. He received numerous prestigious awards from countries including the United States, Cameroon, Cote d'Ivoire, and Senegal. He serves on several international advisory boards and has authored over 250 peer-reviewed scientific articles. Earlier this year, he was appointed as a WHO Special Envoy on COVID-19. John has been an outspoken and highly effective leader in the COVID-19 response in Africa, which overall has had a much lower rate of cases and deaths than in Europe and North America. You might say that John Nkengasong is the Tony Fauci of Africa, or you might say that Tony Fauci is the John Nkengasong of the United States. John has been a visionary and determined leader for the COVID-19 vaccination in Africa, and we're very pleased he's made time to speak with us today on this topic and also respond to some questions. John, welcome. Thank you, and over to you, please.
Thank you, Peter, and the organizers for inviting me to be part of this very important meeting. And when Peter invited me, of course, I couldn't say no, because Peter is not just an old colleague, but a friend for many times. We've shared work together in Thailand or in Africa for over so many years. So Peter, it's an honor to be part of this conversation. In the next couple of minutes, I plan to do three things. One is to very briefly give you an overview of the epidemiological situation of COVID in Africa and focusing on the trends. That way, it will provide a nice background and segue into the progress on COVID-19 vaccination in Africa. And then I'll end with some reflections on the implication on what we are discussing today, the AFREhealth and the CUGH. So first of all, the epidemiologic situation. If you look at this curve, starting on the left-hand side, it shows you the total number of cumulative cases that the continent has recorded since February 15, a total of 3.9 million cases with about 3.5 million recoveries, and unfortunately and sadly enough, 105,000 cases with a case fatality rate of 2.7%. Our case fatality rate has actually reversed. Last year, the case fatality rate on the continent was 2.2%, and the global average was around 2.4, but now the global average is 2.2 and the continental average is 2.7. If you now look at the curve on the right-hand side here, it shows you on the vertical axis the daily COVID-19 cases, and on the horizontal axis, it shows the months since February last year when the first COVID cases were reported in Egypt. And the red line, of course, is the 7 days moving average. The different colors are important to note. They represent the different geographic regions of the African Union. That is the Central, the East, the North, the Southern, and Western African countries. There you can see very clearly on this map that Southern Africa is the region that has been most affected with the COVID pandemic. That is the purple color there, and mainly driven by what is happening in South Africa. As you can see on this curve, we have also, as a continent, observed 2 peaks. The first peak was around, or call it the first wave, around July, August in 2020, where at that time we were recording about 18,000 cases of COVID-19 per day. And the second peak that looks like a steep increase around the December-January period coincides with the holiday season, where there was a lot of movement, of course, towards the end of year holiday celebrations. And we now were recording about 32,000 cases per day. But since then, we continue to see a sharp drop, as you can see on the curve there, the red line. If you take South Africa, the continent, if you look at the continent, the epidemiological situation on the continent with South Africa and without South Africa, you still see that the trend is maintained. For example, on the left-hand side there, you see the epidemiologic curve with the decreases, remarkable decreases over the last couple of weeks with South Africa. Then you take South Africa off because South Africa is accounting for about 1.5 million cases out of the 3.9. You see that the trend is maintained across several countries in Africa. Then you now look at the different regions, the 5 geographic regions, and over the last couple of weeks, the last 4 weeks indeed, you look at Southern Africa with 1.8 million cases, with a decrease over the last couple of 4 weeks of about 74%. West Africa, about 55% on the right-hand side. The North Africa, a decrease of about 50% in the last couple of weeks. So I think that is what we are seeing. Then we had to now develop a continental strategy, vaccine strategy, which was endorsed by the Bureau of the Head of States in August last year, and has 3 pillars. One is to organize the continent so that we are involved in clinical trials as much as possible. And that working group is chaired by Professor Slim Karim from South Africa and Professor Sambaso in Mali. Then the second group there, or pillar, is the mandate for us to secure continental access to adequate vaccines. And that group has been chaired by Strive Masiwa, who is a businessman from the private sector that President Cyril Ramaphosa signed as when he was chair of the African Union all of last year. And the last pillar is the ability to remove barriers for delivery. That is addressing issues related to regulatory delivery and uptake of vaccines. And I'll try to touch on all of them shortly. But before I go any further, I just wanted to use this slide on Central Africa and East Africa to make a point that although we see in the first 3 regions that are indicated, that is the North, West, and Southern Africa, that there are declines, there are 2 regions that are of concern. That is Central Africa, that we continue to see a 34% increase, and East Africa. East Africa is remarkable because if you look at that carefully, there is the first wave around August last year, the second wave around November, December, and now you're beginning to see that there's a 3rd wave coming up slowly at the end of February, beginning of March. So that is very important. The point, as I removed the 2 regions from the other 3 regions, was really to highlight the importance of having timely access to vaccines on the continent, that without timely access of vaccines to the continent, you continue to see those waves coming in and out of the continent, and they have tremendous impact on the health of people, tremendous impact on the economic ability of the continent. So let me now discuss what we are doing. We have a simple formula on the continent that says vaccines plus vaccinations equals life saves. And we have set ourselves a target of at least 60% of the population to be immunized. And that translates to about 720 million people on the continent. And that will require about 1.4 billion doses of vaccines. And that is very important. I circled the middle portion of this curve, which is the vaccinations, which is really our ability to focus on the need to equip vaccination centers with at least 5 things. First of all, storage facilities, vaccinators or personnel, continuous supply of vaccine-related items like gloves, masks, face shields, syringes, needles, alcohol, and of course, a good information system to track people that will come in for the first doses and then engage the community. I think that is extremely important. Without focusing on vaccinations, we may have vaccines arriving, as you see shortly in the next slide, on the continent, but translating it into saving lives will become problematic. Then we get ourselves into the valley of death, where we cannot move from left to right. So this equation is extremely important for all of us. Now, to achieve that 60% goal, CUGH has been a tremendous facility. In my view, CUGH represents and symbolizes that cooperation, global cooperation, symbolizes global solidarity. CUGH has agreed or has stated clearly that they will be able to supply the continent with at least 20% of the needs. That leaves us with a gap of at least 40%. So the African Vaccine Acquisition Task Team, in abbreviation AVAC, was set up by President Cyril Ramaphosa when he was chair of the African Union last year. And we have secured, and you probably saw in the press release that President Ramaphosa issued, about 270 million doses of vaccines. And we are in active negotiations looking for additional vaccines to get to that target. We believe that as a continent, by June of this year, we should be able to have immunized at least 120 million people so that we can progressively begin to move towards that target of 720 million by the end of 2022. So where are we as we speak now? A series of countries are beginning to vaccinate at different levels. The first 10 of the countries you see there, 11 I highlight in red because these are all COVAX countries that have started receiving vaccines in the last couple of weeks. And we want to believe that that will continue so that we can achieve our target of immunizing at least 60% of the population. This map shows you with specifics where the vaccines are and which vaccines are being used on the continent. The green color shows you where the AstraZeneca vaccines are being deployed, and the numbers are indicated there. I will not go into the specific numbers. The orange color shows you where the Moderna vaccines are being used. That is essentially in Rwanda. And then you see the Johnson & Johnson is being used in South Africa, the Sputnik vaccine in some other countries like Guinea and Algeria there. So this map will continue to be colored, and we are tracking it very closely, not only in terms of people immunized, but which vaccines are arriving, who is providing the regulatory authorization use, and how are they being used. And this slide shows you some of the reality of the continent that we are factoring into our vaccination strategy. We recognize that more than 90% of the infections in Africa are in the age group below 60 years. More than 80% of the cases are symptomatic, as I showed in the epidemiologic curve. And that means that there's a lot of young people that are asymptomatic and are reservoir for this virus. The second picture there shows the women in the marketplace. About 2 of them are wearing a mask. Many others are not. And that just shows you the reality on the continent, that 80% of the employment is in the informal sector. There is the public health measures that are being applied are being used at very different levels, and lockdowns are having a devastating effect. So I would show this slide to show that it is not enough to vaccinate only the healthcare workers or vaccinate our elderly and those with underlying diseases. We must target these individuals that are driving the economy in Africa. Otherwise, will remain the continent of COVID going forward. And these young people bring in COVID into multi-generational homes. As you know, that we have few elderly people, but they are there. And these young people will bring the COVID into families. So what is our approach? We have agreed that as a continent, we'll do an approach which we call a phased and iterative approach, which means that we get started with major cities, because that is where the burden of the virus is, or the pandemic is. If we take Ethiopia, a country of 100 million inhabitants with 5 million residing in Addis Ababa, and the rate of infection or the caseload in Addis Ababa is 60%. It makes sense to try to block that spread in that major city, break the backbone of the pandemic there before you go into remote areas. We also recognize that we need to keep stretching our efforts into those areas, but as vaccines come in, we have to protect those cities and build additional capacity for storage, personnel, what we call vaccinators, and also avoid disruption in routine immunization and build new systems for patient registration. We are very concerned that with the 2 doses of vaccines, with the exception of Johnson & Johnson, that the rate of loss to follow up might actually be great. So we are working very hard in that space as well. This slide shows you one additional challenge that has come up, which is the variant issue. And at Africa CDC, we are tracking the continent, how these variants are spreading. The red color shows you where the B117 variants are, have been identified. I'll leave that for you to read those countries: Algeria, Gabon, Algeria, and Senegal. Then the blue colors indicate where the B1351 variant have been identified. And then the purple area are those that have identified a mixture of those variants. So you see that the continent is beginning to be very colored with these variants. I think we are putting in a very strong protocol for systematic monitoring of how these variants are evolving on the continent. And this is the network that Africa CDC has put together. We have organized ourselves at 3 levels. First of all is the national level that we are supporting, and you can see countries map out, and then the regional level, and then a specialized level, which is the labs in major specialized labs in Nigeria, and 2 of those in South Africa. You can consider them as supranational labs. We have contributed about 8,000 genomics into the database, and our goal is to ensure that 50,000 genomes are generated within the next 10 months using this architecture that we've put in to support the continental sequencing, because of the importance it has for our vaccine rollout strategy. This slide shows you where we are with the capabilities or potential for continental manufacturing. We recognize that we will not be able to meet our needs going forward if we only rely on supplies from outside. And we also have to think past this current pandemic. And there are certain countries there, like Pasteur Institute in Senegal, the South Africa group that has Biovac and Aspen, where they are currently already manufacturing vaccines. And then in Egypt, you have the Veracera that is already manufacturing some vaccines, and Tunisia is manufacturing BCG TB vaccines. The Institut Pasteur in Morocco is manufacturing a whole variety of vaccines. So the continent has some potential that in green, that if we support and in a very deliberate manner, we can begin to change the narrative about continental manufacturing there. And because of this, we, Africa CDC and the African Union Commission, will be convening a meeting to discuss continental manufacturing of vaccines on the 12th of April. It will be a high-level meeting chaired by Chairperson Moussa Faki, and will be in attendance will be President Ramaphosa from South Africa and President Tshisekedi, who is the current chair of the African Union. And in order to facilitate regulatory components, that we now have a task force called the African Regulatory Task Force that is made up of a partnership between the African Union, Africa CDC, the AU, NEPAD, and WHO AFREhealth, where we have developed guidance on how to streamline uptake of regulation of vaccines and use on the continent. You probably have seen that we already issued approval for the AstraZeneca vaccine. In the coming days, we'll be issuing further authorization based on our own continental review processes there going forward. So to summarize and conclude, we have see that we have to continue to intensify our efforts for vaccine acquisition, vaccine delivery, and support continental manufacturing. All of this will require that we invest in political leadership that speaks to the will and also commitment. It's not enough to talk about political will, but political commitment is very important. And lastly, strong partnerships, public health institutions, civil society, private sectors, academia, and donors are extremely important in light of this. I think if we apply ourselves to build capacity across these lanes outlined, I believe that we will meet our target for achieving the 60% vaccination by 2022. If we do not do that, my fear is that Africa becomes the continent of COVID, because I have no doubt that Europe, United States, and other countries in China and Russia will vaccinate, and it will become extremely difficult to live with COVID on the continent of Africa. I thank you for the opportunity once more to present this update to you all, and I look forward to working with CUGH going forward. Thank you.
Thank you.
John, thank you so much for a really outstanding talk about the epidemiology and really great vision and leadership on the vaccine issues, including the vaccine production. There's some questions coming in the chat, but let me just start off with one of my own questions about just your vision for the manufacturing. And I know this is difficult to speculate, but do you see more possibilities with the RNA, the mRNA vaccines, or the adenovirus vector vaccines? And then in terms of actually, starting, I guess, with fill and finish and then going on to actual manufacture, what do you think the time course for this will be?
I think the time course, Peter, is that based on our assessments of the green countries that are indicated there, that some of them in the next 6 months, if we support them in a very focused and deliberate manner, they should be able to do some of the manufacturing, like the Pasteur Institute in Senegal should be able to take on some of these abilities and capabilities. South Africa already, as you know, the fill and finish is going on with the Aspen group in South Africa. So it's not, so we have to do this in phase manner, where we look at the fill and finish, we look at transfer of technology, intellectual property going forward. I think that is all doable. I think I'm more optimistic now based on the assessments we have done on the continent than I was at the beginning of this pandemic. So, but it requires strong partnership. It requires partnership with organizations, governments in the United States, Europe. But I'm very excited that the movement is on. I had a meeting yesterday with, I was on a call, a webinar conference yesterday with mostly the Europeans, with, of course, the USAID and others, US government. And I think no one is opposed to that. I think rather I can see a lot of cooperation. I think this is a clear area that we can exercise global cooperation.
Thanks. We have a question from Jean Nachega, and he's asking about any plans to capitalize on the availability of community health workers to include training for vaccine delivery, leveraging from prior work on HIV and TB, and maybe more broadly, if there's a role for AFREhealth in the education capacities of universities in this.
No, absolutely. AFREhealth, please know that you have a natural partner with us. I think feel free to pick this conversation offline, and we will discuss how to actually work. We need all hands on deck. We have deployed about 16,000 community healthcare workers across Africa, about 16,000. And we are now in the process of adapting and retooling our strategy going forward, so that some of them or most of them should really be engaged in community education on vaccine delivery, because we really have to strengthen the demand side of the vaccines in Africa and help the community own the process, help the community lead the process, and using these community healthcare workers that we already have the assets in the field will be a question of how do we collectively work to supplement that effort and really support them to stay in the field and continue to do their good work.
Thank you. I wish we could talk for a longer time. We only have a few more minutes. I'm just going to read a few questions in the chat and let you pick them off. So one is asking about why the vaccine numbers are much lower for Africa than the UK and the US. So to speak to those barriers to vaccine acquisition. And then what's being done about handling misperceptions about COVID vaccination in Africa. And lastly, when do you think, what's your prediction of when Africa will achieve 60% vaccination?
So let me start with the easiest question, which is when do I think? I mean, it's not what I think, is what we must do. I mean, we must, as a continent, of course, in partnership with the rest of the world, because this crisis or this war against COVID-19 would not be won by a single country or by a region, but in partnership, is that by the holiday season, the end of December 2022, that we would have vaccinated at least 60% of the population to give it a chance. This is not a vaccination against cholera or ordinary disease, polio. This is a vaccination against a virus that is spreading extremely fast. I mean, extremely fast. I think I can imagine, I'm a virologist for the last 32 years, and I don't know of any virus that spreads this fast. I think it's very, very scary, and we truly don't know much about this virus. We know enough to have developed diagnostics and vaccines, but we truly don't know how this virus is going to mutate and how dangerous it's going to become, or less dangerous. So we should really be trying to vaccinate and deny the virus the ability to spread. The numbers that you see in Africa for vaccines is limited because the vaccine market has been extremely tight. I think we all have, all of us are familiar with what has happened before vaccines were even produced, and that many countries are still very protective of releasing vaccines. We have to acknowledge that, and then begin to think, apply ourselves as to how do we not repeat this sad scenario going forward.
Terrific. Thank you. Quentin, if we can have another minute for John to respond just about the other anti-vaccine issues in Africa, have those arisen, and how is that being covered?
Yeah, absolutely. That's an important question several people have asked. It's about, are there any anti-vaccination trends in Africa, culturally and otherwise, as we have seen in the US? And what could organizations like AFREhealth and CUGH should have, for instance, an education focus, do, if anything, to help allay some of those fears, such as they may exist?
Yeah, I think that's a very good question. That we did early on conduct a study with, in collaboration with the London School of Hygiene and Tropical Medicine, with Heidi Lawson, a very soundly designed study in 15 African countries, covering more than 15,000 participants. And the outcome of that study was clear, that the rate of acceptance of vaccines range from about 60% to 90%. So if it depends on how you look at it, I mean, it tells you that you're either the glass is half full or it's half empty. If you look at it, the lower spectrum of that, there's 60%, 65 or so, it means you have a lot of work to do to get those 40% of the people that are skeptical. So our work is not over, but the encouraging news is the other side of the numbers, the 90% or so. That means that, I mean, we are very, very encouraged that this situation can be improved. Now, Africa is not a country. I mean, I love to always say that Africa is a country continent, and you have to unpack that very carefully to see trends by region, trends by culture. And this is where we are going to, in order to be successful, we are going to need a lot of behavioral scientists across Africa to get involved. We need to have anthropologists engage, behavioral scientists engage, and we also have to develop a strategy that will counter the social media that is really polluting a lot of this and propagating this. And I'll just end by saying that when I tackle this issue, I say to people that you have the ability to stop this, to stop misinformation and intoxication on vaccines by not forwarding that WhatsApp message or whatever that you receive. Because the intent of those who create it is for you to become, to replicate that. You look at this, it might look very silly, but you send it to Peter, and then Peter laugh at it and send it to somebody else, but you are propagating it. So I think what we should all say to ourselves is that if I get it from somebody, I delete it, so that it ends with me. So I think that is a campaign that we should all commit ourselves to.
I think just to end, if you can maybe clarify, and I think Flora Katz asked that as I did as well, and is there a role for AFREhealth and other organizations like CUGH to help educate people, and if so, how?
Oh, absolutely. I think that if you recall the slide which I call our famous formula, the vaccine plus vaccination equals life saved, the middle part of that talks outlined 5 things we must do to encourage vaccination. And the bottom of that was community engagement. I think we have to really engage in the community leaders very strongly so that they own the process, that they convene the population to go to the vaccination centers and get the vaccines. I think, and that is an area, a natural area that I see a lot of partnership there, and anybody is welcome there. Let me just say that we have developed what we call the African Vaccine Delivery Alliance. The African Vaccine Delivery Alliance that is open to everybody. Is the coalition of the willing, and who says, well, I want to solve a problem, join Africa CDC and the African Union, and let's go out there and fight this fight and achieve our target by 2022.
John, thank you so much. Thank you for your leadership and for your vision. You've given us a lot to think about, and I think our remaining deliberations, we can focus on this issue about contributing to the COVID response and vaccination in Africa. So thank you, and you can count us as AFREhealth, and if I can say that, and certainly CUGH as partners in the response.
Thank you so much.
Yeah, thank you very, very much. So that was a fabulous talk, very enlightening, and I think gives a lot of food for thought. So we're just a few minutes behind. We'll move straight on with Dr. Andrew Dykins' presentation on Capacity Building Committee of CUGH, and a platform that has been many years in the development and meant to engage partners across the world. Dr. Dykins, are you ready? You had a few slides.
There we go. Thank you, Quentin. Can you hear me okay?
Yeah.
Okay, great. All right, I'll keep my comments brief, but before I move into the presentation, I'm going to tell you about the capacity building database. I'd like to ask everyone to go ahead and get a writing utensil or your camera ready. I'm going to show you a website URL in just a bit. I'm going to ask you to write it down, because the idea here is that we're trying to link together institutions globally to build capacity. So training institutions where there's an existing gap of training capacity, we want to link those to institutions where there are resources and expertise for capacity building available for the development of impactful, robust partnerships, and especially regionally. We have been very fortunate to work very closely with AFREhealth. Dr. Kuguli Mawadi was one of the prior chairs of this subcommittee under at CUGH, and we're hoping to build this database and connect institutions. So let's just move very quickly into the presentation. There we are. So we're all very aware of the human resources for health crisis with a projected shortfall of 18 million health workers by 2030. So I'm not going to spend any time on this, but just to illustrate this point, Africa has in 2013 a shortage of about 4.2 million healthcare workers, and by 2030 a shortage of 6.1 million. Southeast Asia also at 6.9 million in 2013. They're actually improving a bit, projected by 2030, but still considerable shortage of healthcare workforce. We think that developing partnerships to share training capacity is a innovative way and highly impactful, potentially highly impactful way of addressing this issue. So I'm just going to tell you a little bit about our website. It's a platform meant to engage institutions, particularly those who want to list their specific training needs. And secondly, for those who wish to list trainers that they have who are interested in providing this training. So we're inviting academic institutions, governments, and NGOs in low and high resource settings to use this platform to share their needs and expertise. So we would like for you to register. I'm going to tell you how in just a bit. Share your specific training needs or training resources, and approach institutions who may meet the needs that you have. So we hope that this will develop robust partnerships. The scope of this is very broad, and you'll see that in just a bit. I'm going to show you some screenshots from the actual platform itself. And it is up to individuals, partners, to develop and maintain their partnerships. Again, the technical focus is very broad, and it's available for everyone. This is open access. All right, this is what the website looks like. And you can see here at the top, there's a register button and a login button. So I'm just going to show you very briefly what it looks like to register. It's pretty straightforward. Back to the main screen. I'm going to highlight this area here. There are two buttons that you can push: trainers needed or trainers available. And you'll select one of those when you want to input, catalog, whichever area you choose. And then there's a search button here. I've highlighted that at the top of the screen. In addition, you can also press institutional training needs and training expertise offered here, so that you can select whichever one best fits your institution for any particular. We would suspect that any given institution could have training needs as well as training expertise in other domains. So when you select the trainers needed button, it'll take you to this. And so you can see that we have a wide range of different expertise that could be selected. And so this is very broad. Most will probably choose here at the top of the list, but there are others that might be available where you can share your resources. The rest of the questions here, it's a very simple form: trainers needed in technical skills or research skills. And then, are we targeting professionals, technical associate, or paraprofessionals? And then we ask that you fully describe your area of need or expertise, and then submit. And that's it. It's pretty straightforward for the time being. Trainers offered, as you'll see, is actually very similar, just right on par with the other submission. Okay. So once you have submitted one or multiple training needs or training expertise, then you can go to the search button. You can search all submissions, or by trainers available or needed. And this is what it looks like. We did a focused experience on cervical cancer. And you can see here we've got some cervical cancer catalog entries on this screen. And you can also, at the top of the screen here, you can search specifically for a particular area that you're looking for. So you can search specifically for cancer, and then it will come up with more directed, targeted submissions. There is also a rudimentary social component to this. You can enter your own profile, do a little bit about me, where you're located, and how to get in touch. And you can send messages within the platform to other, or you can post updates. And so I would like to encourage everyone to go to CUGH capacitybuilding.org and submit your information. You can also send messages. I sent a message to Keith asking Keith, hey, Keith, spread the word about the capacity building database. Tell your network to go to CUGH-capacitybuilding.org. Oh, there's a typo. How about that? All right. And so this is what it looks like. Again, this will be most robust if we engage. So please share this URL among your networks. Go ahead and go and register for this. Keep in mind that our subcommittee has a very energetic and committed group, and we are going to continue to improve this platform in the coming months. In order to do that, we definitely need institutions and individuals to sign on and catalog their existing training needs and expertise. We would also welcome your engagement with our capacity building subcommittee, especially those that might have a programming background, but others with a particular interest in this initiative as well are more than welcome. So there's an email at the bottom of the page if you have additional questions, info@cugh.org. And again, this is the time to utilize your writing utensil or take a picture. The website is www.cughcapacitybuilding.org. All right, thank you so much. It's absolutely been an honor to develop this along with our partners, and we hope that you find this useful.
Thank you, Dr. Dykens. I know this has been a huge effort. It's gone on many years and with some hiccups along the way, but I'm glad and grateful for the persistence of that committee, as are we all. And it can only work if everyone participates. So thanks again very much to your efforts and everyone else's, Dr. Mawadi and others. So let's move straight ahead. And again, it's a tight schedule, so I feel like a cattle herder here. We're just a couple minutes off target. We're moving on now to the subcommittee report backs, and those are listed here as research, education, and student exchanges. And depending who's ready, I'll just take them in that order, which will be the research committee first, which will be the Jana Shega and Peter Kilmarks. You can either share slides, let us know if you want to, or just talk straight to the group as you prefer. So Peter and Jean, how did you want to do this? Jean, okay.
John, you going to go ahead?
We can't hear anything yet, so I don't know who's moving the slides.
Okay.
John, are you there?
Can you hear me?
Yes, good, excellent. There you go.
Yeah. Hi everyone. My name is Jean Ashega. I am an infectious disease internist based at Stellenbosch, Cape Town, South Africa. So I'm gonna just give a few quick highlights about recent work me and my colleague at AFREhealth has been busy doing, actually given the urgency of COVID. So I will only talk about our COVID work. Just as a quick, you probably heard about this paper, which is creating a lot of buzz on social media by a postdoc from Nigeria, is an NIH postdoc who just published in BMJ Africa Contribution to Science of COVID, highlighting that only 3% of COVID research is from African author. So this is something among other capacity building, AFREhealth has been trying to tackle, to try to reverse and to make a difference. And one area has been definitely from our prior research on COVID, the new insight in DRC, we highlight really the need to get more data on some key population, vulnerable population of pediatric and pregnancy. Some early sign data show us unacceptable mortality in children, which in contrast of what has been experienced in Europe or in United States. This collaboration going to increase increasing sample size, power, but also try to really look at a specific condition in Africa, comorbidity, which can impact outcome like HIV, TB, malaria, but also non-communicable diseases like sickle cell disease or rheumatic heart disease. And then it's gonna allow us to compare some predictor and outcome across Western, Central, Eastern, Southern African region, while again, putting at priority those key population. And most importantly, to try to strengthen South-to-South intra-African collaboration in research, which has been also something really where we can improve. So AFREhealth did embark on really calling a protocol which involves several partner and investigator from Francophone, Anglophone, Lusophone, including multi-professional doctor, pharmacist, lab scientist, public health biostatistician, on trying to address pediatric COVID research in Ghana, Nigeria, DR Congo, Kenya, South Africa, and Uganda. So our protocol was published in CID. We had the same protocol for pregnancy. And at this stage, I'm speaking, we quite wrapping up the data collection. And this weekend, we're going to start the analysis. Just to give you a quick highlight of the data, the recruitment stage. We've been able to recruit about, to pull about 350 pregnant COVID positive, and also about 400 pediatric COVID. So this is quite remarkable, and this is across Kenya. South Africa, we have 3 sites, Stellenbosch, University of KwaZulu-Natal, University of Pretoria. In Uganda, we have Makerere University. In Ghana, we have two sites. In DRC, we have 4 institutions. In Nigeria, we have 2. So I'm gonna stop there, and we should have the preliminary result early next week. So at my subsequent CUGH talk next week, I will be able to share some preliminary results for the pregnancy data. Thank you.
Thank you, Jean. I was just curious whether you or as part of the research committee or Peter would like to comment on discussions that you've had on the research subcommittee of the AFREhealth-CUGH committee. If
you want to respond?
Yeah. Or whoever, either. So,
yeah. So, Quentin, I can just chime in about the CUGH research committee.
Yeah, go ahead.
Okay, so thanks. So again, I'm Peter Kilmar. I'm the Deputy Director of Fogarty and also the co-chair of the CUGH Research Committee, together with Dr. Judy Wasserheit, who's the chairperson and professor of global health at the University of Washington. She and I started together in March of last year, 2020. And the goal of the committee is to carve out areas for expanding collaborative global health research and research training in priority areas. We have 25 members. Many are from the US, but also from elsewhere in the Americas, Europe, Africa, and Asia. We have 11 that recently joined as new members and have quite a diversity of subject area expertise and also career stage. We meet monthly. We've developed working groups. Judy and I have asked members to come forward with focus areas that they're willing to commit to lead and to implement. And so we have a focus on climate change and global health, a group working on addressing the anti-science movement, and then a group involving the campus representatives of CUGH on research committee projects. And so we also, with our new members, looking at other priority areas, ways of engaging with CUGH members and supporting global health research. Richard Deckelbaum, who was here, had to leave this meeting for an hour, but is coming back. he's our liaison for the AFREhealth Research Committee. So we're also very eager to identify areas of mutual interest and potential joint activities. So we want to encourage those in this meeting to join us in our breakout room and really give us guidance on what we can do to support the research interests of our members and specifically about strengthening contacts with AFREhealth and CUGH. I'm very impressed with what Jean has accomplished. I've actually been involved with one of his projects and we're keen to have more collaborations. Thanks.
Okay. Thank you, Peter and Jean. Excellent work there. So we'll move on to the Education Committee, and I'm going to ask Judy Cagnola, with whom I co-chair that committee, to give a presentation. She'll talk mostly about the Interprofessional Health Initiative, and I'll just say a little bit about virtual learning. Judy, did you want to?
Yes, good afternoon, everybody. Good morning for those of you who are on the other side of the world. Like Quentin has said correctly, I work with him. We co-chair the education subcommittee together, the AFREhealth, the CUGH. And one other hat that I wear within AFREhealth is also the chair of the IPE-TWG. And I just wanted to very briefly talk about the work of the IPE-TWG to just give a sense of what AFREhealth is doing around IPE within AFREhealth. So one of the things that we are doing within AFREhealth under the TWG, the Technical Working Group, we have a two-pronged approach where we're looking at, number one is advocacy. So we want to advocate for IPE within health professions, education, research, and service in Africa. And the second approach is to provide technical expertise in IPE for whoever may, feel that they would need that. Just like Jean has said before me, there is a dearth of IPE, just like research in Africa. And this initiative is critical moving forward. By profession, I'm a nurse, and oftentimes one of the challenges I face within my work as a nurse is just the hierarchical way of doing things and the siloed approach we have to patient care, which, as you know, and even which COVID has brought so starkly to us, is not really the best way to do that. So AFREhealth is looking at making sure that we embed IPE, we begin to talk to each other, we begin to collaborate with each other within the professions to make sure that really the focus is the patient and that we are able to achieve the best we can for the patient. So within AFREhealth, the IPE-TWG is looking at supporting, for example, the various training institutions we have, the schools of medicine, pharmacy, nursing, the lab professionals, and so on and so forth. All of those schools need to begin to, for example, include IPE in their curricula. We're looking at also advocating through ministries of health, for example, to have policies and some of these guidelines changed to include IPE. And then in the realm of the technical expertise, like I mentioned, we're looking at ensuring that we have a database of various experts within IPE to help anybody that may need help. We are still very much at the beginning phases. We actually just started this early this year to put the IPE-TWG together and begin to have these initiatives moving forward. So all of you brothers and sisters around the world, please join our hand, help us to move IPE forward. Quentin, I'll stop there and hand back to you. And thank you very much for giving me this opportunity to speak.
Thank you, Judy, and for speaking about that. And I can remember one of the very early meetings of the ACWG when the Education Committee was asked to decide on its focus, that many people felt IPE was the correct focus, and it's been a challenge getting that off the ground. So I'm very gratified to see that AFREhealth is moving in that direction. I just want to add the second initiative that the committee is interested in is the virtual learning platforms and how to do that given the COVID-19 pandemic. CUGH, myself and others have launched a big survey. We'd ask those of you who get it to complete it about how people are coping with global health programming in the pandemic. And in the education breakout session, there will be 3 short talks about virtual learning platforms, which may be of interest for AFREhealth, which I know has also been interested in this topic and have had sessions on it. But these are 3 global groups that have been working in this domain. So if that's of interest, consider joining that. So thank you very much. That's the Education Committee report. And I'll ask now the student exchanges, that would be Faith Nwagi, I think, or Anna Iacone, to give their brief presentation. Faith or Anna?
Yes, Quentin, it's Anna. I'd like to share my screen because I have a couple of slides to share, if that would be okay.
Yeah, just click the green button at the bottom.
Okay, great. So first, I just want to thank everyone for this opportunity. And on behalf of ECFMG and FAMR, we wish to extend our gratitude for your continued support for the GEMX Student Exchange Program. So my name is Anna Iacone, and I am one of the senior associates at FAMR. And I am here with my colleague, Faith Nwagi, who is also an integral part of the FAMR team. So we've been doing a lot of work together for many years. And so we're just going to give you an update on the work that we have been doing in the student exchange space. So student exchanges became part of the ACWG as a result of ECFMG FAMR's existing partnership with AFREhealth through GEMX, the ECFMG Student Exchange Program. And that relationship was built, I think it was in 2016 or 2017, when we developed a formal partnership with AFREhealth. And so the work that we've been doing, and through Faith's good work, we have been able to facilitate student exchanges across the African continent by developing intra-institutional partnerships among AFREhealth member institutions. So it was in Durban, South Africa, where student exchanges was solidified as part of the ACWG working group. So what happened with North-South student exchanges? Well, COVID happened, and that just, everybody's lives and every institution had to deal with that crisis. But in 2019, we had potential partners in North America, namely the Wayne State University, that was very interested in partnering with us, as well as Sidney Kimmel Medical College in Philadelphia. But COVID happened, and those discussions broke down, and because we had to handle what was going on in our respective health systems, as well as ECFMG FAMR dealing with it with its own crisis. So that's what happened. But Faith and I have been working on a solution to engage students from the global north and students from the global south, and we think that this new concept will be very sustainable in the many years to come. It will be affordable and equitable, and we really will be able to link the students globally. So we'll talk about that, but I do want to update you a little bit on GEMX Interprofessional Education Student Exchange Initiative that Judy was talking about at the clinical level. And so the IPE student exchange was expected to happen in 2020, and of course COVID happened, and all mobility stopped, and the GEMX program was suspended. However, we continue to work with the 15 institutions in 11 country locations, as you can see in the map. And the one thing I want to talk about, even beyond launching this interprofessional education virtual mobility initiative that was approved just yesterday by the executive group at AFREhealth, and we really appreciate your support, AFREhealth, for this. But the relationships that we have developed with these institutions on a personal level. And I really have to thank my colleague and friend, Faith Nawaji, for doing such great work with connecting with the leadership at these institutions. And I can say that the leadership and people at all levels are very excited about the collaborative work that is going on across the continent. So we're really thrilled about that. And if you want to hear more about the Interprofessional Education Virtual Mobility Initiative, please attend next week's, I think it's March 13th, which is a Saturday, the session on responding to Africa's health challenges through North-South and South-South partnerships, the case of AFREhealth. So Faith will be giving a deep dive into this program and how it's working. And again, we had to pivot really quickly to bring forth this initiative. And again, it would not be possible without the support of AFREhealth. So here's what we were thinking. And
so, Anna, can I just interrupt?
Sure.
I'm getting several messages that
Sure.
you think you're sharing slides, we're not seeing any slides. So just we can see you, but not your slides.
I am so sorry.
Yeah.
Oh boy, I am so sorry. Why is that? Let me see.
It may not be necessary, but just wanted to.
I just want, even if we could just see the map, that's really important. Does everyone see the map?
Now we do. Now we do. Thank you.
Okay. So these are the 15 institutions in 11 country locations that I was talking about, and where we're developing the interprofessional education student exchange model virtually, which will be a 4-week attachment for students of the health professions. And like I said, Faith will be talking more about that next week and at the session responding to Africa health challenges through North-South and South-to-South partnerships. But we're making great progress in this area, and I'm sure that it will be successful as it has been our previous work. And so this is the new concept for student engagement, we like to call it, where we would be working with AFREhealth, and Faith and I had preliminary discussions with the AFREhealth student committee, and where GEMX would play the role of helping to develop AFREhealth student network. And so with that, we would be able to link the AFREhealth student network with CUGH, the Training Advisory Committee. And so that way we would be able to link these students together, and they could lead their work in areas of collaborative research, global health projects, hybrid models of exchanges. So we think that if by developing a framework for the development of the AFREhealth student network, that we would be able to move forward a robust program where students from the Global North and students of the Global South could come together and work on projects that are meaningful and impactful. So that's what our group will be talking about during the breakout sessions. And we encourage those of you interested in this area to join us. Thank you.
Thank you, Anna. You can stop the share, so the slides.
Yeah.
So what's going to happen now is we turn into the breakout sessions, and they should be appearing on your screens shortly. We're on time, we're doing well. I hope those discussions in the separate groups were fruitful and interesting. This is an opportunity for each of the groups to give a report back on what was discussed in the group. Either one or both, 2 representatives from each group can discuss what was talked about in your group and how you see a path forward in the coming months till our next conference. So I think I'll go in the same order with research. Jean or Peter or Judy may want to give the group some insights.
Go ahead, Peter. Yeah.
Yeah, thanks, Quentin. I can go ahead, and I see Richard Deckelbaum,
Hi, Richard.
our liaison, was not able to join our breakout, but he's here now. So I'll just speak for a minute and then see if Richard wants to add anything. But in our breakout, we also talked about what is the CUGH Abstract Advising Program, where we reached out to CUGH and AFREhealth members to link together early career people submitting an abstract with more senior people to give them advice on their abstract for this CUGH meeting. And so there's interest in we're evaluating that now, but in continuing that to have broader opportunities for early career and senior people to link together and kind of micro mentoring opportunities and to have that continue to be a CUGH and AFREhealth activity. Also expanded more on what John had talked about in the main session about really the terrific work that he's done in linking together these multi-country assessments of COVID-19 impact on pregnant women and perinatal outcomes, and learned that the Gates Foundation has actually followed up with them about making it a global analysis. So that's really, we think, a terrific example of using the power of the network of AFREhealth to bring together researchers, and that's really what CUGH also offers is a network. So if you're within your specific domain, you might already have a network, but if you want to reach out to other fields of research or education or across different countries, that CUGH and AFREhealth offer that. We also had some input. Andrew Dykins talked about how going beyond assessing the healthcare worker capacities to also have assessments of training capacity, both for healthcare worker training, but also for research training, that could be an important way forward. And then just lastly, I'll mention an observation about how the challenge of healthcare workers interested in research, that they don't have the protected time or the support to be able to pursue that. So we took that as a common challenge going forward. But let me see if Richard has anything to add in his role as liaison.
Yeah, I guess, okay, I'm on, and so I apologize that I had to miss this meeting, but I had something scheduled for 5 months that I have to be at for about an hour. I just want to say that, you know, having been with GHEC and CUGH, and now having had the privilege to be working and being the liaison with AFREhealth, I'll keep it very brief, but wow, I am so impressed with what the research committee and Jean, the group, have been able to accomplish in a number of spheres, from not just the COVID pandemic, but in really establishing processes for webinars, mentoring, and many active activities is terrific. And I think going forward that in the next 2-3 weeks, we're actually going to be working on very specific low-hanging fruits where we'll take CUGH and we'll take AFREhealth and we'll do the equation 1 + 1 = 3 to 4. So we're talking about synergies.
John, anything you want to add?
No, I think you sum well things. No, thank you. Interest of time.
Okay, thanks very much. If we end early on this session, I'd ask the COMFEX organizers, and I'll message them to open it up for the general discussion, because there may be, maybe we can open all the mics then if that's feasible. There may be questions, but I want to ask Judy Cagnola, the co-chair of the Education Committee, to summarize what we talked about. Judy?
Thank you, Quentin. The Education Committee had very I must say, interesting discussions. It's clear there are two things we need to do moving forward within Africa through AFREhealth. Number one is interprofessional education and collaborative practice. I think that just goes without say. And then number two, which came out very, very well in our breakaway session, was the virtual learning platforms. We were able to hear from 3 different virtual learning platforms, Scholarex, Lecturio, and the team from Norway presented a very, very interesting course that they're running around making us actually teach.
Finland.
And yeah, Finland. It's
Don't
Norway,
start a
Finland,
Nordic war.
Nordic Finland. Thank you, Quentin, for that. No, I don't want to start a war. And what came out for me is that the three platforms are are all equally important and have different virtues within them that can be used as needed. And so basically we have a smorgasbord, I think I'm saying. So there's one good thing that has come out of COVID is that it has allowed us to begin to see and do things a little bit differently. So virtual learning definitely is a must. Discussions following these presentations also brought out a few issues. We had from AFREPEN, which is Africa's convening organization around interprofessional education and collaborative practice. And they gave us a quick brief around, their organization and how they've transited in the last couple of years. And so for me, the discussions brought out the key need for context-specific information that's coming to Africa. And these three platforms, the virtual learning platforms, actually answered this by saying that they are working with the Africans, if I may say that, to make sure that whatever content is in there is context specific and is actually relevant to the needs of Africa. The issue of bandwidth, as I'm sure all of us know and experience every day, is a big problem. And again, some of the platforms are able to be downloaded directly on the phone, don't require internet access, which is a plus for us here in Africa. Another issue, of course, was funding. And again, it was very nice to hear that all the platforms can work around the issue of funding to make sure there is a win-win for whoever requires to use these platforms to then deliver their education. In terms of a way forward for our committee, we are now deciding to marry the virtual learning platform and the IPE. They're going to get married and make a lovely, wonderful new family. So this is our way forward within AFREhealth, using the power of network that has been said earlier, AFREhealth's power of network, to then drive the IPE agenda through the virtual learning platform forward in Africa. I'll stop there. Thank you.
Thank you, Judy. That was incredibly well summarized. Wonderful. Very rich discussion. The organizers are telling me that once we've finished the 3 report backs, it seems like people can talk if they want to, rather than going through the chat room. So keep yourself muted if you're not talking, and so we don't get background noise. But if you do want to talk, then I think we'll have an opportunity to talk through the mic. So I want to ask the Student Exchanges group, which will be either Faith or Anna, to give a report back on what happened, was discussed in your group.
Sure. Thank you, Quentin. So, so Professor Abigail was in our group, and it definitely appears that AFREhealth is on board about developing an AFREhealth student network. And with that, we talked about the need for developing their goals and objectives and a vision. We've also understand that there will be a meeting on Sunday with the AFREhealth group to as a way forward for the development of the AFREhealth student network. We talked about areas of focus around capacity building, leadership and management. We talked about resource mobilization, translational science, social innovation, collaboration on global health community projects, just some of the outputs that, or the expectations that the student network would be engaged in, and really the need to build up the AFREhealth network and to train the next generation of leaders, of global health leaders. And we also talked about the composition of the student network and what that would look like, at what level of student engagement that would be, from the undergraduate level to those students who are actually in clinical practice. And so our expected timeline, and this is just Faith and I talking with Professor Abigail, that we're expecting a 5-month timeline to get this, the structure in place and really develop a way forward. And then the long-term goal is to link students from the global north and the global south in a very meaningful and sustainable way moving forward. So once we are able to develop the AFREhealth student network, that will definitely be sustainable, and it will be around as long as AFREhealth and CUGH is around. So we feel really good about this decision, and because we just can't continue to think that we can't keep doing the way we have been doing it as a result of a global pandemic and other things in the future that might come along. But with the virtual space, we'll be able to accomplish much.
Thank you. And I'm not sure if Faith is available to, if she wants to comment as well. Faith, are you on? I thought I saw your name. There you go.
Sure, I am. I think Anna summarized it so well, and we look forward to 5 months of being at work and ensuring that this is accomplished. Thank you.
Okay. So I think we have time now for discussion and before the summarizing at the end. So this is an opportunity for all the groups to interact and ask questions of each other, make suggestions. We have a good amount of time, about, seems to me that we have 20 minutes before the next closing session. So I will just make a couple of comments that I think COVID has provided both opportunities and challenges, as we've noticed, and the group should continue meeting through the year rather than just at conferences. I would strongly like to encourage all 3 committees to meet regularly and to set an agenda for the year. And the timing is often difficult to set a meeting. It has to be an early morning in the US for CUGH and afternoon for AFREhealth. But I really want to emphasize that, and will be a concluding remark as well, that the 3 groups do continue to meet. But I want to open it now for discussion. I've been looking at the chat, and but it seems to me that you're able to unmute your mics and ask a verbal question if you want to. So feel free, anyone, to ask a question or make a comment. Stefan,
I see a hand raised.
Yeah, Stefan, I think.
Thank you, and thanks again for having me join this illustrious discussion, Quentin. Just wanted, since a lot of educators are present and we're talking about contexts with, low capacity in terms of health workers, whether it be community health workers, nurses, or doctors.
Stefan, can I just introduce you? Not everyone knows who you are.
Oh, sure. Okay, I'll let you do it, Quentin. Absolutely.
Okay. Stefan gave a short presentation on he's the CEO of Lecturio, that has a fabulous platform located in Germany and does a lot of work in African countries. So he was in the education session.
Thank you very much, Quentin. Yeah. And we're located in Germany. Most of our educators are from the US. So we work with a global a group of educators across a number of institutions: Hopkins, Harvard, UCL, Imperial, so some European as well. But my key point or encouragement to all of you as educators and capacity builders is this. I think, of course, digital platforms can make education more efficient, more student-centered, drive blended learning, make it smarter, everything, be more data-driven in the teaching, everything else. But my appeal to you is, let's not take the Western models of, bricks and mortar medical schools and try to replicate that for Africa. You know, to my mind, just like healthcare delivery in the US is a particularly good example for this, is in many cases overpriced and inefficient. If you look at what you're spending per GDP in the US, it's quite striking. You know, the outcomes are not much better and sometimes worse than in the UK, for example, where they spend a lot less. But I don't want to get into a big discussion on systems. My point is more fundamental. You know, the way we drive medical education these days, if you look at the fee levels in the US, but also elsewhere in the world, the way it's approached, whoever pays it, Germany, it's all free, but you know, the taxpayer still pays it, so I pay it as well, is very inefficient and dated in the way that we do it. You know, it's kind of too bricks and mortar intensive. And so I just want to encourage and invite everyone to accept that we need to really rethink how it's done. And I think Africa provides an exciting opportunity to sort of leapfrog in the model, you know, and ideally have, you know, colleagues in Germany, UK, US, point at places like South Africa or other countries where we drive this, you know, and say like in 5 years' time, you know, this is how we should do it, you know, just like in the education session I was mentioning, the India example of glaucoma surgery. We need to do these large-scale examples in education and change of delivery of the education and really leapfrog in the model, because, you know, otherwise with the population growth that we're facing, I don't think we're gonna really turn the tide around in terms of increasing shortage of community health workers, nurses, and clinicians. That's my invitation to all of you. We're doing some interesting things there, and happy to discuss those in groups and one-on-one. And I think we need to think large scale there and work together to achieve those things.
Thank you, Stefan. That's a critical comment that we don't, and there's so much in the literature about, you know, decolonization and all of that. I think we all need to be acutely aware of that framework, and that, you know, as the book Turning the World Upside Down has said, we have a lot to learn bilaterally. Any other comments? You can either just talk or raise your hand.
Quentin?
Yeah.
Roger Glass here.
Hi, Roger.
Can you hear me well?
Yes, perfectly.
I just have to tell you how proud I am of this group coming together, CUGH with AFREhealth. It reminds me that about 12 years ago, when Francis Collins became head of NIH, he launched the CUGH on the NIH campus. And about 10 years ago, we launched the MEPI program and the NEPI programs, which have led to the HEPI. So, and those principal investigators came together for AFREhealth. So this coming together of a large network over a period of about a decade has been, to me, unbelievable. And if you recall, at that first MEPI meeting, it was the 50th anniversary of the African Medical Association. They had 14 members at the time and hadn't met for years. And I think this AFREhealth group, with the participation of so many African schools and the health sciences, has been just transformative. Furthermore, while we've all been struck by the COVID this year, I remember in the MEPI program, introduction of tablet PCs to medical students, a totally new innovation that was empowered by the sea cable going down East Africa about a decade ago, and that allowed schools to come into this digital learning setting. So to see this expand now to medical schools, nursing schools, and high schools is just a unbelievable transformation. It's like electrification in the United States way back when. And it's both a terrific advance, and the COVID has also identified the problems of equity, of adequately reaching all people through this network. So my own son's a medical student who's been learning from the virtual platform this past year. He's getting the same materials that so many of you can get. I'm also impressed by the ability of the AFREhealth network to become a clearinghouse where we at Fogarty have been sending opportunities for fellowships, for research announcements, and for partnerships. And I know, for instance, that Rishi Desai, who has spoken in AFREhealth before and runs Osmosis, one of those virtual networks, has offered not only all the material from Osmosis free to low and middle income countries, but also the ability to train so that Africans can make your own virtual platforms and teaching that's sensitive to local activities. So just looking at this group, I see Jean Chega, who has these wonderful symposiums on COVID as an African symposium. There's so many of you. I'm just proud of what's happened, and know that we at NIH and at Fogarty are incredibly supportive of this activity as we've been from the start. It just, it's wonderful to see this grow and know that you have our full support going forward. Thank you.
Thank you, Roger, and for the historical perspective as well. You can see the trajectory over many years. Thank you so much.
Yeah, thumbs up.
Yeah, good. Any other comments? I think we have 10 more minutes or so. Abigail as the current president, or Mariki as the past president, would you like to weigh in?
Well, this is Abigail. As AFREhealth, we really appreciate this opportunity, and we have learned a lot, and we have heard a lot of presenters offering connections, and we wish to seize those opportunities, and we will be looking forward to linking up with you so that we can develop the network further, and also for the resources that you have put across for us to tap on. For sure, we'll be working towards tapping on those resources, and we appreciate your support. Thank you.
Thank you, Abigail. Mariki, are you there?
Hi. Yes, hi, Quentin.
Yeah.
Good afternoon and good morning, everybody. I just want to say that I want to add my voice to Roger's voice. I think where we have been and where we are now, it is actually just amazing. And as this will probably be my last ACWG meeting, I just want to thank everybody that I could work with. People are just amazing and enthusiastic and taking things forward. And it's great to see how new people are coming in with new enthusiasm, new ideas. And for me, that's just the one, it's sustainable. I can see the sustainability in this because of the people in the initiative. So I just want to say thank you very much. It was a very great afternoon, and the fact that we could still see each other, although not in person, that's also nothing short of a miracle. So go well, and this work will go from strength to strength. Thank you, Quentin, for the opportunity.
Yeah, thank you, Mariki. As you were talking, I was remembering how we chatted after the Accra meeting about setting this group up, and there was a small group of us who drew our chairs together in a circle and started talking about setting up this collaborative group. And thank you for your incredible leadership over the past years. And you may think you're finished with the ACWG, but you're not. You'll remain engaged with us. You have a lot to contribute, and we're not going to let go of all your expertise. So, anybody else? Otherwise, I'll just call on people.
I have a question.
Go ahead, Tal. Yeah.
That's okay, Quentin?
Yeah, absolutely.
Sure. Again, it's a pleasure to be with you all. My name is Tal Lee from ScholarX, a learning group in the United States. Question for the group. We've had with regards to sustainability and collaboration, I'd be curious, what experience you all have had in terms of involving junior physicians or medical students or junior health professional students, even in the work that you do, whether it's education, the student exchange, or even research. They're obviously going to be the future, in some ways of many of your organizations. They bring a lot of energy and creativity to the table. We've been blessed to work with the Medical Student Alliance for Global Education, which I mentioned earlier is a consortium of 7 international student organizations, 1.3 million medical student members, which have 27 national medical organizations in Africa alone. And so they're all contributing, to needs assessment, to global curricular development and so forth. And so again, we've been very amazed at their again, like I say, their energy and industry. And I was just curious to see if there are other opportunities for student or junior professional involvement in AFREhealth and CUGH.
Would someone like to comment on that?
Yes, Tal, this is Anna Icone. And
yes.
So yeah, we have, we've been working with other student organizations. In fact, we were just on a panel with the IFMSA, the International Federation for Medical Students Association, and one of their challenges that they were expressing is the inability to get, I'm going to talk medical school buy-in for global health attachments. And then we were having this discussion, and one of the other things that is happening in medical education, I can only speak to medical education, is this whole accreditation initiative with the World Federation on Medical Education and these regulating bodies that are accrediting individual medical schools. And so one of the things when we talk to IFMSA, because they are a strong advocate and their voices are heard, and they are doing amazing work in research and in exchanges, is to link them up. They sit on the With Me Executive Council, and one of the things that we talked about was, what if having this high level discussions of talking about medical school curriculum to embed global health elective attachments into it. I think that's the only way we're going to get traction, is to involve the medical schools in this conversation, because what they're experiencing is resistance at the medical school level. They also talked about the bureaucracy, and understandably so. One of the challenges with IFMSA is it's student-led, right? And so when students show up at another host institution without the administration knowing about it, that's always been a problem too. So we've been working with them to give them some strategies on how to embolden their exchange program, because you have to get buy-in at the institutional level. And I think that they're struggling right now as well. But we welcome a conversation and dialogue. And in fact, GEMX was very instrumental in developing the student network organization of the Network Towards Unity for Health as well. And Faith, you could talk about, the work that you have done in Africa that has been incredible and impactful. But the bottom line is we really want to bring in these students, because they are the drivers, and they have the energy and innovators, and they're highly adaptive and all that good stuff that we look to our students for. Faith?
Sure, thank you. And I would just probably add a little. Here in Africa, we've been able to promote the regional mobility concept that is commonly known as South-to-South mobility and all that. And we've seen remarkable learning outcomes that are transformative across the continent, where we currently partner with 56 institutions in 15 African countries. As a result, students have been able to gain knowledge that is applicable back home. It's much more cost-effective. They've been able to acquire the same learning domains of going for an international medical elective out of Africa and within Africa. When we were able to measure according to the learning outcomes and values of international medical electives, there were similar values that the students have been able to gain. As a result, we've seen a momentum of a need to create a student momentum that is a center for research, that is a body for thought and brainstorming of ideas, but also is a seed to ensure that they learn from the current leaders today, so that they can carry on the light, just as Dr. Abigail always mentions. We need to mentor people to carry on the light and all that. As a result, we've seen remarkable value for regional mobility. which we think should be advanced and probably thought into much more to expand to various regions, not within Africa, but it could be also with a global South concept, whereby it's beyond Africa to other developing countries, but also if it's a concept harnessed within various continents as well, in Europe, in America, and all that. So we've also experienced the ability to see that opportunity is equally available for all domains, and not only medicine, but we have nursing students having electives. We have dentistry students going for public health attachments in their domain and social medicine. We see pharmacy students and all that. So that's just brief, and please attend our panel session on that.
Thank you. Thank you. I have a raised hand from Ayman Mahmood. So sorry to cut you, but we're running out of time.
Thank you. Thank you, Quentin. Thank you. I would like to bring attention to the very potential and valuable role of the professionals in diaspora in the United States from African countries, and their potential role and valuable role in the contribution of education and research, being part of the two-word, and I'm hoping that we can utilize this untapped resource of both communication and making things work in a smoother flow between the North and the South.
Yeah, thanks, Ayman. That's a very, I'm glad you made that comment, because it's come up on a recent meeting I've had with the network and within CUGH about harnessing that also for the new medical schools in Africa. The diaspora is something we haven't looked into, and there's many people in the United States Africans who are keen to contribute to the continent. And I think you and I should be in touch about that as well. I see a hand up there. Can you unmute yourself? I'm not sure who it is.
Sorry about that. I was coming from another meeting. This is Lillian Niwagaba from the Center for Global Health at New York Institute of Technology. And the Center for Global Health is part of the College of Osteopathic Medicine. And we do a lot of work. I mean, there is so much to unpack. We do a lot of work in Africa. We have partners in Ghana and Uganda, hospitals and clinics and healthcare organizations, but also from here, organizations like NextGenU, which is one of the online universities that develop curricula, free curricula for medical schools and postgraduate medical education and those types of things. But also we take our students, we do a lot of student exchanges with our partners. Every summer we take students to Ghana, to Uganda, to see how medicine is practiced, to learn and teach, and those types of collaborations. One of the challenges we have, someone talked about the medical schools not being receptive. We have been lucky, our school is very supportive, but they don't provide funding. Most of the programs are student funded. And some of the other programs we are developing collaboratively with organizations like NextGenU, like Masters in Public Health. And the way we have designed the model, we will be our partners in Africa, like in Ghana, and doctors in Uganda who want to do a Masters in Public Health. They can take that degree program free of charge without leaving their site. So
thank you very much.
Yeah, we just want.
Sorry, we're going to have to end. We were running out of time, but thank you very much, and I apologize.
No, that's all right. Yeah.
But we want to stick to our time because we've also been asked to end sessions on time. Okay. So we're moving now into the last part, the summary, next steps for the AFREhealth-CUGH working group, which Elsie and I were going to do. And I think we can just stay on this call. There's no need to change anything. Elsie, did you want to start off? Okay. Otherwise,
thank you very much, Quentin.
Yeah.
And thank you very much, everyone, for joining our group today. It's been very enlightening, and it is very encouraging to see this collaboration maturing and gaining momentum. Is to see the number of people that has joined virtually is very promising. And I think this is a great opportunity. Collaboration between really supported AFREhealth, because it's much older, it's been around for longer and much bigger, and the AFREhealth is really appreciative. As I see a way forward from the three groups.
Elsie, perhaps you need to talk directly into the mic.
Group is
just talk directly into the mic. Your voice is cutting out.
Well
so yeah, just talk into the mic. Yeah, when your head's turned away, you cut out.
Maybe let me put off.
Okay, go ahead.
Sorry about that. So for the research group, I see mentorship from what I heard from their summary, and I think that is very important. If mentorship for not only for the junior faculty as well as students, and for AFREhealth, that is very important. And just to say something about students, that AFREhealth decided at one of our executive committee meetings that students that join AFREhealth will join for free, so they will not be paying fees, so that we encourage them to join AFREhealth, because we know they are our future. And then from the education group, the issue of making sure that when virtual learning is developing programs, they consider the interprofessional education approach. I think that is also exciting, and interprofessional education and collaborative practice is one of the focuses of AFREhealth. So that is also exciting. I see that as a way forward. So I would like to thank all those that presented that in the education group, and I hope we'll continue this collaboration and ensure that this happens in the future. And for the student group, the formation of the student network and enabling the students to really take part in making decisions, I think is also a very important aspect. And it is exciting that through these student exchanges, we can ensure that there's a leadership capacity building for our students. So I would like to thank everybody for attending. I would like to thank Quentin especially for the energy you bring into this group, for all the work you've done, Mariki and Abigail, and to assure Mariki that there's no way she's dropping off this group, because she's done a lot. And Kate Martin, who keeps working with us, making sure that the group continues. Thank you very much. Over to you, Quentin.
Thank you, Mariki. I mean, Elsie. See, Mariki, you can't run. Thank you, everyone, for joining, and I'm very glad we've adhered to the timing. We have a few minutes, but I do want to, as the CUGH representative, well, I always like to remind people that I was born and raised in Africa and spent more than half my life there. So my body's in America, but my soul is in Africa and will always be. But from a CUGH perspective, I want to remind you, we have enormous resources, and to encourage you to avail yourselves and to approach people at CUGH. The education committee that Dr. Rabin, who's on the call now, chairs with James Hudspeth, and I previously chaired, has 7 or 8 subcommittees, working groups, and they are all really, really eager to help. And so what I would like the group to do in the 3 subcommittees is to arrange regular meetings throughout the year. I know it's been challenging at times and COVID has overwhelmed people, but I think we're stabilizing now. And I also want to thank very, very much the wonderful talk by Dr. John Nkengasong, inspiring talk about the vaccination program in Africa, and all the subcommittee chairs. I know it takes a lot of time and energy. Peter Kilmock, Joanna Shager, Anna, Faith, Judy, for all the work you put in. But the committee members as well, please join the meetings. It's not always easy, but and that as well, Fogarty for their support, Roger, your unbelievable support over the years, and Flora, your background, and so many people we should be grateful. I really would like this partnership to flourish, and not just at conferences, but during the year as well. It's symbiotic, it's mutualism, it's anti-colonialism, it's partnerships. That's what it's all about. So Roger, would you like as our senior guru here to have a final word?
Yes, I just was delighted with the presentations and how this group has matured from an AFREhealth that just brought a bunch of leaders together to really now having a critically important role for health education, interprofessional education, for supporting research, for being a network where ideas can ferment within this group and be distributed throughout the continent. If you didn't have AFREhealth, you'd have to develop it. So the fact that you have this with so many people who have worked together now for nearly a decade from the start, but have continued enjoying along the way, is to me really heartening for where AFREhealth is going and where this partnership with CUGH will take you. I think networking, the use of the virtual platforms, which have been accelerated by COVID, are going to be lasting legacies of this. So full speed ahead. This is a time when there's never been a greater need to network among yourselves for action and for sharing what works and what doesn't work, and including research as a part of the training activity. Thanks so much for all of what you do. It's so exciting to see how this has grown, and only can expect greater things as you go forward. So that's it for me. Congratulations.
Thank you, Roger. Abigail, you're the president of AFREhealth. One more word from you.
Thank you so much. I just want to appreciate all of you for your contributions, and also CUGH and its leadership, and our key partners, NIH, and with that, the list is endless. To say thank you for the support that you are constantly offering to AFREhealth, and also for the goodwill that you have for this network to grow stronger and stronger. I promise you, as AFREhealth, we shall continue to build the association and also to nurture this relationship so that we improve the overall health of Africa. Thank you.
All right. Well, thank you very much, everyone. And we're ending spot on time, maybe a minute over, but I like to keep things on time. And I want to thank everyone for their participation and the smooth running, and the technologists, and everyone went as smoothly as it probably could have gone. So let's keep up the good work and continue to meet on the committees, and stay safe, stay healthy, and get vaccinated as soon as you can. All right. Bye.
Thank you, Quentin.
Bye. Yeah. Thank you, Roger. See you. Bye.
Bye-bye.
Thank you. Bye,
Bye, everybody. Thank you.
Bye. Okay.
Thank you all.
Okay.
Bye.
Bye. Bye.
Bye.
Great. Marieke, thank you as well, huh? Elsie, all of you, Abigail, amazing group.
Thanks, Roger.
It's
Yeah.
it's just, I mean, I'm just smiling here to think of where we were 10 years ago.
Yes.
Yes.
With the original MEPI, which was and I remember that old fella who was the president of the African Medical Association, 50th anniversary. They started out with 14 medical schools in Africa, must have been 1960 or so when MEPI started. They hadn't had a meeting for years, and
Right.
he was so articulate, such an elderly statesman, but without a constituency. And here you have, 60 schools involved, nursing schools and allied health professionals. It's just an amazing progression. Abigail, you're in a great position to lead this group, and Marietje has you've been amazing, and Gina Chega with these symposium have been
Yes.
a quality, not only the quality, but the publications that have come from that.
Yeah,
Absolutely.
So,
yeah, but thank you, Roger. You were believed in us all the time.
well,
that really helped us.
And this is only the beginning. I mean, we're involved now with what we can do with COVID as a way to energize research, training, linking countries because of the need for the surveillance networks, spreading technologies like sequencing of strains, which now can be done cheaply with simple technologies, and is so powerful to understand what's coming next. So I think that, I didn't think 10 years was a long time, but when you see how much has been accomplished in 10 years, it's, I remember the first tablet PC brought to the MEPI meeting. Marietje, you will remember this.
Yes.
I think a Tokwa who brought it from Botswana, it was
yes, she did.
she didn't know how to use a tablet, but all of the students had gone to the library and loaded it. It was and then with Milliard contracting with the Chinese to make 2,000 for his medical students and to bring in another 2,000 the next year. It just gave a whole boost to and the sea cable coming down East Africa to make broadband accessible to the medical schools, schools of health sciences, and the links to more rapid cell phones, so that will be the next thing, the 4G and 5G technologies. Oh, it's nice to see you all. This was fun.
Thank you so much, Roger.
Oh, it's a delight. It's really a delight.
We remain committed.
Yes.
Yeah, thank you. I hope to see you in full.
Well, I hope we can see
sometime.
Mariette and Abigail, I want to be able to give you a hug the next time I see you, because this virtual stuff is just to see you in person.
Okay. All right. Have a good day. Thank you so much.
All right.
Thanks,
Bye-bye.
Abigail.